the atherosclerosis factor, diabetes as a risk factor. I'm Dr. Harikamal, vascular surgery resident, Department of Vascular and Endovascular Surgery from Ramram Medical College. First of all, thanks to Tapisha for giving me opportunity, and thanks to my moderator Ajay sir, and thanks to my professor Sanjay sir, and thanks to my professor Chandrasekhar sir. This is my scheme of presentation: introduction, epidemiology, classification, pathophysiology, evaluation, treatment, and references. Diabetes is characterized by chronic hyperglycemia resulting either from lack of insulin production or from insulin resistance. The health consequences of diabetes are primarily vascular and are routinely divided into micro and macrovascular. The most important microvascular complications are retinopathy and nephropathy, and people with diabetes have a 20-fold increased relative risk of blindness and 20-fold higher relative risk of end-stage renal disease compared to people without diabetes. It is an important risk factor for development and severity of all forms of atherosclerosis, including PAD, coronary artery disease, and cerebrovascular disease. And most of the diabetes-related deaths in the United States every year are due to the coronary artery disease. Over the past several decades, the global prevalence of diabetes has nearly quadrupled, with an estimated 425 million people worldwide currently diagnosed with this condition. Industrialization has led to both the abundance of the cheap, high-calorie food and also adaptation of the sedentary lifestyle. With increased population growth leads to leading to an epidemic of obesity worldwide, which leads to the diabetes as a major problem. And among persons with diabetes in the United States, an estimate of 89% are overweight or obese. Coming to classification, diabetes is classified into type 1 and type 2. Type 1 diabetes is characterized by an absolute deficiency in the insulin secretion, which accounts for 5 to 10% of the diabetes diagnosis. It results from the autoimmune destruction of the beta cells in the pancreas. It requires both genetic and environmental factors to cause this disease state. It presents as acute hyperglycemia or and ketoacidosis. Previously it was known as a juvenile onset diabetes, often present in children and adolescents, but it can occur in any of the age group. It is also frequently develops in the autoimmune diseases like SLE, rheumatoid arthritis, and Hashimoto thyroiditis. Because patients with type 1 diabetes have absolute insulin deficiency, their treatment is insulin replacement therapy. Coming to type 2 diabetes, it results from combination of the insulin resistance and also inadequate compensatory insulin secretion. This accounts for the 90 to 95% of the patients with diabetes. Previously, it is known as a non-insulin dependent diabetes, but this term is less accurate because it may in the further progression of the disease, the insulin may be required in these cases. And also because it can develop at any age group, it is no longer an adult or anything. The pathogenesis is heterogeneous with both environmental and genetic causes are seen. Obesity is strongly related to the insulin resistance. The insulin sensitivity heritability is approximately 40%. The symptoms of this type 2 is very subtle, and they are polyuria, polydipsia, weight loss, and polyphagia. These patients require the titration of different medications to achieve appropriate control of the sugars. Coming to relationship with vascular disease, diabetic relationship with vascular disease. Vascular disease is the most significant cause of morbidity and mortality in patients with diabetes. Microvascular diseases such as retinopathy, nephropathy, neuropathy are more prominent in diabetes, type 1 diabetes, due to its long duration of hyperglycemic exposure. On the other side, glycemic variability has a more deteriorating effect on the macrovascular complications such as coronary artery disease, peripheral artery disease, and also cerebrovascular disease. Coming to coronary artery disease, people with diabetes have present with coronary artery much earlier and younger than the patients without diabetes. It is estimated that patients with diabetes tend to clinically have coronary artery disease as much as 15 years earlier than otherwise what we expect. Once diagnosed with coronary artery disease, patients with diabetes have higher risk of cardiovascular death, stroke, and recurrent MI and coronary stent thrombosis. Following MI, people will with diabetes have higher rates of morbidity and mortality. It has 50% higher mortality at 1 year of at 1 year. In patients with diabetes, risk of peripheral vascular disease is increased by older age, smoking, and also duration of diabetes, and also presence of peripheral neuropathy. The distribution of this peripheral vascular disease is different in patients with diabetes when compared with the non-diabetics. Because patients tend to have involvement of more distal arteries in diabetic patients, particularly the popliteal and tibial arteries, making the limb salvage more challenging. And coming to neuropathy, first there is a decreased proprioception and pain sensation there due to sensory neuropathy, thereby reducing the ability to avoid injury by decreasing the normal sensation and also withdrawals to pain, which may blunt the symptoms of advanced ischemic disease, leading to delay in the diagnosis. Second is diabetic peripheral neuropathy also leads to limited joint mobility due to motor neuropathy, which leads to formation of swan neck deformity, resulting in the disproportionate increase in the pressure points at the metatarsal heads and also in the other parts of the foot, and making ulceration more common in these patients. Coming to cerebrovascular disease, diabetes is associated with at least twice the risk for stroke, a 2 year earlier age of onset of cerebrovascular disease symptoms, and worse functional outcomes compared with the non-diabetics. And when these patients treated with thrombolytic therapy for acute stroke, these patients have higher failure of recanalization and increased risk of hemorrhagic conversion. Coming to pathophysiology, diabetes leads to increased atherosclerotic vascular complicated by a number of mechanisms, including metabolic dearrangements, hypercoagulability, inflammation, and also vascular dysfunction and neuropathy. These alterations result in the normal phenotypic change in the blood vessel to atherosclerotic or atherogenic phenotype, characterized by endothelial cell dysfunction, oxidative stress mediated by increased production of free radicals, and also platelet hyperactivity. The two fundamental dearrangements which cause endothelial dysfunction are hyperglycemia and insulin resistance, which are independently associated with the atherosclerotic development. Vascular endothelial dysfunction is the key mechanism that initiates the inflammatory process associated with the vascular complications in diabetes. Vascular endothelium has a very important role in the vascular homeostasis by regulating the vascular tone, platelet activity, leukocyte adhesions, diabetes, and also vascular smooth muscle cell migration and proliferation. Endothelium-derived vasodilator nitric oxide is constantly producing healthy endothelial cells by endothelial nitric oxide synthesis, which requires BH4 for activation. In addition to its potent vasodilatory properties, nitric oxide also has another mechanism of reducing the production of pro-inflammatory chemokines, cytokines through inhibiting the inflammatory transcription factors, thereby limiting the platelet and also limiting the platelet activation. In contrast, endothelial dysfunction found both in hyperglycemia and impaired endothelial insulin signaling may link insulin resistance to its heightened risk of atherosclerosis, MI, and death. Thus, endothelial dysfunction play a key role in the development and progression of atherosclerosis and may facilitate in the adverse complications or adverse sequel of the atherosclerosis. Hyperglycemia impairs vascular function through an increase in the production of reactive oxygen species, oxidative stress, and consequent impairment in the endothelial function. Increase the mitochondrial generation of the superoxide anion, leading to cellular mitogenic pathway activation, and leads to enhanced advanced glycation production and protein kinase C activation and nuclear factor kappa B mediated vascular inflammation. These advanced glycation end products bind to the receptors and cause increased superoxide production, and thereby causing and that promotes the macrophage induced vascular inflammation and also decreased synthesis of nitric oxide by decreasing the expression of the nitric oxide synthase enzyme, and also increase the endothelin 1 expression, further contributing to the further increasing the endothelial dysfunction. The upregulation and nuclear translocation of nuclear factor kappa beta subunit P65 and also transcription of the pro-inflammatory genes encoding for monocyte chemoattractant protein 1 and vascular cell adhesion molecule 1, intracellular adhesion molecule 1. All these cause increased adhesion of the monocytes to the vascular wall, and thereby translocating these monocytes into the subendothelial spaces and subsequently formation of the foam cells. And the other one, these are all caused by the hyperglycemia. But the other second factor which causes plays important role in pathophysiology is the insulin. Insulin resistance. This insulin resistance, initially insulin signaling involves two major pathways. One is the phosphorylate inositol 3 kinase dependent, and also the mitogen activated protein kinase dependent pathways. This phosphorydyl inositol 3 kinase dependent pathway, which it will help in the nitric oxide production in the homeostatic state. But this is impaired. This signaling pathway is impaired in the insulin resistance, resulting in the decreased nitric oxide production. And the other pathway, MABK dependent pathway, get activated into insulin resistance and cause increased endothelin secretion, thereby causing endothelial dysfunction. Adipose tissue has an important source of inflammatory mediator and free fatty acids, which are elevated in the plasma of the obese patients with type 2 diabetes. The free fatty acids induced by oxygen species production by increasing expression of NADH oxidases, and they also inactivate enol by production of superoxide, and increase vascular susceptibility to oxidative damage by increasing the intracellular concentration of glutathione, and activate the inflammatory cascade by activating the pro-inflammatory factors like NFK beta. The atherogenic effects of insulin resistance are also due to the changes in the lipid profile, such as high triglycerides, low HDL cholesterol, increased remnant of lipoproteins, and elevated ApoB, and small and dense LDL. The ApoB is formed by once circulating free fatty acids reach the liver, and then VLDL get assembled and made soluble by the increased synthesis of the apolipoprotein B, and then VLDL are also processed by the cholesterol ester transfer protein, allowing transfer of triglycerides to LDL, which becomes small and dense LDL. All this leads to become more atherogenic, and this atherogenic dyslipidemia causes cardiovascular risk, and more common in the type 2 diabetes mellitus and the metabolic syndrome patients. And diabetes mellitus and atherosclerosis appear to be connected through several pathological pathways, and in this picture I will discuss about those pathways. I will go by one. First, according to dyslipidemia, this most studied link between the diabetes and atherosclerosis is the dyslipidemia. So native LDL particles do not cause any lipid accumulation in normal cells, hence they do not cause any heterogeneity. But when the normal phenotype is modified to atherogenic phenotype, this causes the changes in the physical and chemical characteristics of the LDL particles that trigger the massive lipid accumulation in this. And once the lipid accumulated, this will penetrate into the subendothelial space, and these will reside there for a longer duration of time, and they will interact with the proteoglycans, and therefore have increased chance of being internalized by the lesion cells. These processes result in formation of the foam cells. And second pathway is hyperglycemic pathway. After exposure to higher glucose levels for a certain period of time, there will be generation of the advanced glycation products. These are called metabolic memory or legacy effect, which occurs when blood glucose levels are high and these are not metabolized. These molecules influence the endothelium activation and surface expression of the adhesion molecules, thereby promoting the adhesion and entrance of the macrophage into the endothelium and into the subendothelial space during the initial phase of the plaque formation. And also, moreover, these molecules enhance the cytokine release by the macrophage, thereby maintaining the pro-inflammatory state within the plaque, within the developing plaque. And then a protein kinase C pathway increased glucose uptake by the vascular cells result in the synthesis of the diacylglycerol, which is an activator of the protein kinase C. This protein kinase C activation can also result in the oxidative in response to oxidative stress. This enhanced protein kinase C has numerous pro-atherogenic effects because by reducing the production of the nitric oxide and also impaired vasodilatation and endothelial dysfunction and increased production of hello, sir. Uh, can I continue, sir? Recently, they found out that there is a role of non-coding RNAs, circulating RNAs in the diabetes and atherosclerosis. These are the possible biomarkers and also dense modifiers. Among the microRNAs which are relevant for atherosclerosis with diabetes is MIR146 and MIR126, which have received much attention recently. Coming to platelet dysfunction and coagulation cascade, glycoprotein 1B and 2B3 expression is upregulated in diabetes, which leads to increased amounts of von Willebrand factor and platelet fibrin interaction. Uh, and also hyperglycemia impairs the calcium and magnesium homeostasis, which alters the calcium-dependent platelet aggregation and activation. And procoagulant factors like factor 8, thrombin, and tissue factor are also increased. And endogenous anticoagulants like thrombomodulin, protein C, plasminogen activator inhibitor are all decreased in the chronic hyperglycemic state. Diabetes therefore leads to the increased platelet aggregation shift in favor of the procoagulant state in the thrombotic cascade. To summarize the platelet abnormalities, it is like altered calcium and magnesium hemostasis, increased advent acid metabolism, increased thromboxygenative synthesis, decreased nitric oxide, and decreased antioxidant levels, increased expression of glycoprotein 2B and 3A, and increased platelet turnover. Finally, to summarize the pathophysiology, diabetes causes hyperglycemia, increased free fatty acids, and also insulin resistance. All this leads to oxidative stress and advanced glycation production and protein kinase activation and activation of the receptor for the advanced glycation end products. All this leads to decreased nitric oxide, increased tissue factor, increased pro-inflammatory factors like nuclear factor, kappa, beta, and endothelium 1, which all leads to vasoconstriction, inflammation, and thrombosis. Vascular evaluation. Coming to vascular evaluation of diabetic patients is a challenge which requires comprehensive assessment, particularly evaluation of the neuropathy and thorough foot examination and mono-invasive physiological testing. So foot examination should focus on the inspection of the extremities, feet, and also for signs of any skin changes, hair loss, any dryness, and full sensory motor examination should be performed with the addition of monofilament and vibration sensation pinprick and ankle, and to check for the ankle reflexes. And when coming to peripheral neuropathy, diabetic peripheral neuropathy has a symmetric sensory motor polyneuropathy. It starts distally and progresses proximally, resulting in a typical glow and Stockholm distribution. And also, in diabetic patients, there will be falsely elevated ABA results seen in patients due to non-compressible tibial vessels. In these patients, flow pressures and transcutaneous oximetry are more reliable because as the pedal and distal vessels are usually spared. The American Podiatric Medical Association and Society for Vascular Surgery recommend that patients with diabetes have patients with diabetes should have a ankle brachial plate index measurement annually when they reach 50 years of age, and patients they have any history of diabetic ulcers or any prior intervention or prior abnormal vascular examination or known atherosclerotic cardiovascular disease. And Wi-Fi classification system is useful in the evaluation of diabetic foot ulcers. It is a framework for stratifying the amputation risk and revascularization benefits in patients. If patient have good functional status and average surgical risk with stage 2 stage 3, they can undergo revascularization. Or with the patient with a Wi-Fi stage 0 or 1, they can undergo for local wound care. And when there is a poor functional status, they can undergo for primary amputation. Uh, Coming to treatment, the two most important goals in the treatment of diabetic patients with peripheral vascular disease is improving the limb outcome and also decreasing the morbidity and mortality. So, the target-driven medical intervention can reduce the risk of cardiovascular events by as much as 50% in patients with type 2 diabetes. So, so the preventive foot care is very important in diabetic patients. The peripheral neuropathy, ischemia, and foot infection, all these are acts as a etiological form as etiological triad for diabetic patients and cause diabetic foot complications. So, proper foot care and hygiene are very important in these patients. Um, Only these patients have ulcers and infections begin as small ones due to the neuropathy and go unrecognized, and they cannot get treated in the early stages, and we and get progress to increase the chance of infection. So the Society for Vascular Surgery and mm, an American Podiatric Medical Association provide more specific recommendations for prevention of diabetic foot ulcerations, like annual foot examination and inclusion of the Sims-Winston test for peripheral neuropathy as a component of the foot examination, patient and family education for preventive foot care, and customized footwear in high-risk patients, and maintaining the HbA1c less than 7%. Uh, and coming to glycemic control, Accord trial, which was stopped early because the intensive glucose lowering strategy was found to increase the cardiovascular mortality without reducing any events. And also advanced study also failed to and establish any reduction in the cardiovascular outcomes. Based on the lack of success in these trials, so American Diabetic Association recommended a HbA1c level of 7.0% to be maintained. Uh, and also they published an algorithm. According to this algorithm, uh, lifestyle intervention is the first step of the treatment along with metformin, if not contraindicated. And if HbA1c level is 9, greater than 9%, or lifestyle intervention and maximum tolerated dose of metformin do not achieve hemoglobin or less than 7%, another medication can be added. But if HbA1c is more than 10% or like glycemic control is still not achieved on dual therapy, insulin therapy should be started according to the American Diabetic Association algorithm. When insulin providing therapy was compared with insulin sensitization therapy for glycemic control in the bypass angioplasty revascularization and investigation to diabetes Barry 2D trial, the insulin sensitization, they established that the insulin sensitization strategy was shown to be much superior in the reduction of peripheral vascular disease and also need for vascularization and also need for lower extremity amputation. And the proactive trial, they established that uh, pioglitazone didn't have any effect on cardiovascular outcome, but it has a significant effect on the decrease in the amputations at 10-year follow-up. This is the table showing the briefly reviewing the different classes of medications which are available to treat the hyperglycemia, like biguanides, sulfonylureas, glinids, and alpha-glucosidase inhibitors, thiazolidine incretin modulators, DPP4 inhibitors, and insulins, etc. Coming to risk factor control, uh, the American College of Cardiology and American Heart Association guidelines on that guidelines state that blood cholesterol to be maintained with moderate intensity statin therapy for primary prevention of atherosclerotic cardiovascular disease in diabetics who are at the age of 40 to 75 years of age, to be maintained with LDL greater than 70 milligram per DL, to be maintained in these patients who are having LDL greater than 70 milligram per DL. And also high dose statin therapy recommended for those who have age 20 to 75 years old with LDL greater than or equal to 190 milligram per DL. In these patients, high-dose statin therapy was recommended. Coming to hypertension, in meta-analysis, intensive blood pressure treatment achieved a 14% relative risk reduction of vascular events and 22% relative risk reduction of stroke events compared to the less intensive treatment. The current American Heart Association guidelines and American College Cardiology for the management of hypertension, they recommended that blood pressure to be maintained lower than 130 by 80 mmHg in the patients with diabetes. Antiplatelet therapy is a key component in the secondary prevention in the patients with diabetes and atherosclerotic risk. So, in a CAPRI trial, they observed that patients with non-ST elevated MI and ischemic stroke or peripheral vascular disease, they observed that patients treated with clopidogrel with clopidogrel have 12.5% reduction in the major adverse cardiovascular events when compared with the aspirin alone. And recently recommended is dual therapy with aspirin 100 milligram daily and rivaroxaban 2.5 milligram twice a day has demonstrated reduction in the both major cardiovascular events and also major adverse limb events in two recent clinical trials. One is COMPASS and Voyager trial. So in COMPASS trial, the dual therapy demonstrated a reduction in the adverse outcomes compared to the low-dose aspirin monotherapy alone after 21 months of follow-up. In Voyager study, they demonstrated that 2.6% absolute risk reduction in the major adverse cardiovascular events and major adverse limb events with aspirin rivaroxaban compared to aspirin alone in patients with peripheral vascular disease who are undergoing revascularization after 3 years. So the SVS guidelines suggest that monotherapy with either monotherapy with clopidogrel or dual therapy with low-dose aspirin and rivaroxaban should be considered in patients with critical limb-threatening ischemia. Coming to exercise therapy is effective in improving the glycemic control and endothelial function in diabetics. So the SVS recommends walking a minimum of 3 times per week for 30 to 60 minutes for at least 12 weeks is recommended by the Surgical Vascular Society. And cilostazol is a phosphodiesterase 3 inhibitor, and it causes vasodilatation, anti-proliferation, and antiplatelet effect. The recommended is 100 milligram BD for claudicants for at least 3 months. It is contraindicated in congestive heart failure. Finally, the treatment algorithm is to summarize smoking cessation, and also BP should be maintained less than 130 by 80, and HbA1c levels should be maintained less than 7%. Antiplatelet therapy to be given as a dual therapy with aspirin and rivaroxaban or clopidogrel, and use of statins in patients who are with risk factors, and also exercise therapy and the preventive foot care, and considering the angioplasty or bypass surgery for patients who are critical limb ischemia or disabling claudicants or non-healing wound, and amputation is concerned when there is non-salvageable limb. Finally, an article on the diabetes mellitus atherosclerosis connection, the role of lipid and glucose metabolism and chronic inflammation by Anastasia Poniak et al. They concluded that both types of diabetes mellitus have shown to be independent risk factors for accelerated atherosclerosis development. And the known pathological mechanisms connecting diabetes and atherosclerosis are dyslipidemia, hyperglycemia, with advanced glycation end production and increased oxidative stress and inflammation. Finally, the take-home message is hyperglycemia and insulin resistance are the two important factors which cause endothelium and platelet dysfunction. Good glycemic control is an important factor we have to consider in diabetics, and proper surveillance in patients with diabetes and peripheral artery disease will prevent them from progressing to critical limb ischemia, and early treatment prevents them from morbidity and mortality. Thank you.